Welcome to this week's episode of the TPT Connections podcast. Thank you for listening so far to previous episodes, and thank you for your comments and your feedback. We really appreciate it. Keep subscribing, tell your friends about it. This week, we have a very special guest, my good buddy, Anang Chokshi. Anang is a physical therapist, digital healthcare expert, and entrepreneur who seeks to employ innovative technologies and evidence-based clinical pathways with laser focus on the patient experience. He currently serves as the Chief Clinical Officer at IncludeHealth, and he held a similar position at Reflexion Health. His experience and skills include evidence-based clinical care in the areas of orthopedic and sports-based physical therapy, digital healthcare, and telehealth reimbursement models, and go-to-market strategy, remote patient monitoring, value-based care, product vision and development, FDA and regulatory experience, and clinical research and trial design. Anang has got the goods. I was super impressed with him the first time we spoke, and we got to hang out at CSM a couple of years ago. We've been good buddies since. Anang is a true pioneer and a leader in digital healthcare. I think you're going to enjoy this episode. Please continue to send us your comments, your feedback, subscribe to the show, TPT Connections podcast. We really appreciate it. Enjoy the episode.
Welcome to the TPT Connection podcast. Physical therapy information, innovation, and insights for patients and providers. Physical therapists and innovators Dan Seidler and Adrian Miranda will help you connect with your neuromusculoskeletal system, discussing how to care for every physical ailment they've ever seen or heard of, the latest digital health technology, and other fun stuff from their PT toolbox. Great guests, 21st century home remedies, exercise thumbs up or thumbs down. Now, here are your hosts, Dan and Adrian.
Okay. Welcome to the TPT Connections podcast. My name is Dan Seidler. Adrian, that's your cue.
It's Adrian Miranda.
That's right. And our
well, today you said I'm going to introduce Adrian. Usually you say introduce myself.
I confused you again, huh?
Yeah, did.
We'll get it. We'll get it one day, man. We'll get it right. Our very special guest today is Anang Chokshi. And Anang, great to see you, man. We talk all the time, and it's really good to have you on.
No, thank you very much. It's great to connect again, and it was a pleasure to meet Adrian for the first time. Even though I've followed him on YouTube and many of the other channels out there, so it's great.
Oh, well, we've both been following you, and we know we know a lot about your work, and I want you to have the opportunity to talk about it a whole bunch today. Some of the things you've done in the past, some of the things you're doing now, and of course the future, because we're always talking about the future. You and I, Anang, we met 2 years ago, I guess it was, at CSM.
Yeah.
In Washington D.C. That might have been the last. Was that the last live one, or was there was another one?
There was one in Denver. There was Denver last year, right? So
that's right.
Yeah. So
yeah, we got to hang out. We hung at the bar. You watched me drink. It was a good time.
That's right. Watching you dance. Okay. Yeah. So I shared some of the food that you bought, but that's about it, right?
That's true.
That sounds like a real PT conference, actually.
That's right. That's right.
We did talk about playing tennis, which we haven't gotten to do. Have you been playing much tennis?
I've been, you know what? I think I picked up the game of the game of the pandemic, which is pickleball. I think pickleball has gone crazy everywhere.
Right on,
so that's the pandemic game. So I picked up pickleball, played a lot of pickleball, and I am playing some tennis. But ironically, I might play some pickleball later tonight. So
nice. It's so funny. I learned about pickleball. Do you know what pickleball is, Adrian? Yeah.
Yeah, she treated patients who played it. So
okay, yeah. I saw it down in Florida. My parents, they like every time I go down there, they've converted another tennis court into 4 more pickleball courts. And I always thought it was like for people who were 60 and over, but I mean, it's really not. I mean, it's for anybody. Just like
quite a bit. Yeah, it's fun. It's a fun game. It's it's a little addicting, and it's fast to pick up, which I think people who are it's fun that way. You can have some rallies versus in tennis. Sometimes you can end up picking up the ball more than you have rallies. So,
do you feel like your tennis skills carry over to pickleball?
Yeah, I've always been a doubles player in tennis, so playing the net game in pickleball, it helps, right? But nice. It's altered my tennis game a little bit, where I'm trying to do too much of a touch versus kind of I've lost my ability to kind of. I'm thinking too much of tapping the ball versus actually hitting through the ball. So
that's interesting. That's funny. Yeah, it's that happens with other sports too. I think like if you
squash or racquetball sometimes, right?
So, yeah, totally. Like racquetball is more wrist and messes up your tennis game for sure.
That's right.
That used to be my issue. Yeah. Anyway, good. I mean, good that you're getting out and playing some sports, of course. Yeah. The last time we talked, you had just started a new position, but let's talk about Reflexion Health. That was your old job. I mean, you did something big there. You did some really great things there, and I think the whole Reflexion project was a pretty big endeavor. How did it all start? And just give us some background on that.
Yeah, it kind of started back in 2000, in I think 10, 11. It kind of spun out of a company organization called the West Health Institute out here in San Diego. It's a research organization that's looking at ways of kind of reducing costs in healthcare and kind of moving towards aging in place. And there were a couple of 2 or 3 guys there, or people who were looking when the Kinect camera came out, kind of said, "Hey, this is an interesting concept." One of them was a internal medicine doc, and he was like, "This is interesting. I refer people to PT, but I don't know what they're doing. Can I use this technology in a way to understand what patients are doing and how they're doing, and giving them some feedback?" And so I kind of I knew one of the guys, and they kind of reached out to me as a kind of a consultant, just to kind of drop some ideas and hit it and ask some questions. And at the time, I was managing a practice outside of LA in the area called Westlake Village, and we had some tech in the clinic, and so they came up there. We talked. It kind of intrigued me a little bit, and I just kind of joined their advisory board as a healthcare advisor and kind of the subject matter expert, and just kept on asking more questions and getting into it more, and realizing over the time, I've always been looking for something like that in terms of how to help patients beyond the 4 walls of the clinic, even way back then, right? I think everyone has, and the way I would do it back then was just to simply give everyone my cell phone number. Every patient had my cell phone, right? And I said, just call me, text me anytime, and so as a way to help them whenever they had a question, because obviously all the questions don't pop up in the clinic, and when they're on the field or at the grocery store or whatever it is, when they have certain questions. And they kind of evolved over that time, and the company decided that they were going to turn this idea of this concept into a kind of a project. And they asked, would you want to join? And I looked at my wife, and we just had twins who were 6 months old, and the kids 2 and 3. And we had one she was probably at that time probably almost just 4. And I said, you know what? And she's living in LA, and this job was in San Diego. I said, you know what? I can always go back to treat. Let me go see what this whole startup world is like, and see what happens. And kind of left traditional practice and joined the startup. And that's it. Haven't gone back yet.
That's wild. All right. So a couple of questions from that. First of all, did giving your cell phone to patients, did they use it?
They used it, right? But not as much as you would think. I think it was a part of a way just to make sure. I think a lot of things that we do as PTs it's just making sure as patients, they want access, right? And so if you can give them access to care or access to have an answer to something, I think it puts them at ease in that. So there are certain people who used it, and certain people I may have, over time regretted it. But I would say 99% of the time, it worked out great. It was a good way to communicate, even, of connecting on the weekends, or even connecting if people are late for appointments, right? I'm running a few minutes late or whatever it may be. It just, it was a good way of connecting besides the traditional way of connecting only face-to-face or on the phone or whatever it may have been.
Yeah, I agree with you on that. And, it's interesting being a telehealth practitioner now, solely telehealth. Everybody has my cell phone, or at least or a number that they can text me at. Right.
Correct.
And I look at that. That's one of the great, one of the things that I have found to be a huge advantage compared to my previous existence in a clinic. because messages and connections and communication was always going through a front desk, and not that they weren't doing their job, but they were doing 100 other things. And I would get a message at the end of the day, basically, that a patient was running late or whatever their story was. And now, like, I can actually help the patient on the spot. I can help them through the problem at the time. And I'm not really sure why, and we're always discouraged from sharing our cell phone with people. And sorry, there's a helicopter flying overhead as I'm recording. But and other people will often say, and you don't want to give your cell phone to anybody, right?
Right.
I'm not sure why not.
Yeah, I agree with you. I'm in a similar, kind of ilk in that, in terms of doing that. And I think what was helpful, it allows you to even connect with them and say, "Hey, how's it going?" Right? And just any questions after yesterday, right? Just little things to, again, it's goes back with all, engaging the patient as part of your system, as part of your clinic, as part of your care module, right? However you want to do it. It's not just I treat you and only think about you when I see you face to face. I'm thinking about you at all times. So they feel more valued, right? And I think that's always about the important, right? And I know there's many people out there who kind of help clinics. Jerry, Durham, right? And there's others, but talking about the front desk, it all starts at the front desk and your first impression. And I think that's part of it, right? You want to give a good impression to the patient and making sure that, hey, I'm accessible if needed. And fortunately, knock on wood, physical therapy is not usually in the outpatient world, life and death situation. So if you can't answer right away, it's okay, right? To say to them, hey, let me get back to you. Let me call you in a little bit. It's okay. You don't have to be always on. Right? People understand that as well.
Sure. So. There's all kinds of engagement tools out there for the physical therapy for our space. And we may all have it right in our pocket.
Right.
Cell phone.
That's
it.
Oh, that's it. Right. We're all looking for other tools, new tools. It's very simple, right? And even with the things that we, built at Reflexion, and everything, and it's, technology is technology, and technology is just an extension of the therapist. And it's still about the human connection through technology, right? And you can't just replace the therapist by using technology. It's going to work for a short period of time. It's not going to work for the majority of people. You still need that human connection. So connecting that, having that ability to talk to someone, reach out to someone, text someone, leave a message for someone, it's important. It's very important.
Yeah. So getting back to Reflexion, from an outsider's perspective, being that the big the visual that I have of Reflexion is the Duke study.
Yep.
So that was your research.
Yep. Tell
us about the Duke study.
Yeah. So the study we did, at Reflexion, we really took the approach, the kind of a scientific approach, right? We built it. It was one of the co-founders was an MD. Our CEO, who was the last CEO of the company, Joe Smith, is a very well-versed physician, cardiothoracic surgeon, PhD, everything. And so science was always about the backbone of the company and building evidence-based, right? And not just kind of saying things work. And so obviously when you first start, it's expensive. So the first thing is about building the product and making sure, is your idea legit? Is it a legit idea? Will people like it and use it? So with our early partners, that's what we kind of did, is kind of take the product out there, work with some early partners to vet it out, vet out the clinical workflow and understand, hey, is this something usable? Will patients like it? And will clinicians find it useful? And when we found that, then we're like, okay, now we got to do some real research to have a clinical backing in terms of sales approach, having conversations. And, we went down the FDA route as well. And so because of that, we also wanted to build some clinical evidence. And so we partnered with Duke Clinical Research Institute and did a study where we took our technology, and there was 300 patients in the study. 150, half of them got traditional care following total knee replacement, and half of them got physical therapy with the technology. And I remember when we were scoping out the trial design and everything, the clinical team at Duke, which is a great team out there, led by Janet and her team out there. They're saying, okay, well, for the intervention group, we're going to do no in-person visits. And I was like, what? This is total me. Yeah, no in-person visits. I'm like, okay. I go, you have to allow the person to go into in-person PT if they want to, or if the clinician says it's not, right? We got to allow that. She goes, yeah, we'll do that. And I just remember thinking, oh my God, this is pushing the envelope to the far end of it. But we saw that patients who engaged with it, we all, anecdotally, they were not going in as often. I mean, they were achieving results quicker and sooner because they were engaged with their recovery. Because it's the old adage, they're doing something every day, right? And they were doing activity. And so, as the results got published and they came out, the study was a couple of things. The primary thing was to look at cost. Are you able to save dollars and money in this new bundled world environment if you were to compare traditional physical therapy to kind of the remote physical therapy using technology? Next thing was like, okay, is it as safe and efficacious as traditional care? And also, are the outcomes non-inferior? So we weren't looking for superior outcomes, looking for non-inferior outcomes at basically 6 and 12 weeks. So, or in that. So at the end of the results, it found that we were able to save a significant amount of dollars, $2,700 compared to one. And a lot of that was because the part of it was the patients were engaged because where they were found to have done 5.9, engaging with the system and doing 20 to 25 minutes of activity, 5.9 out of 7 days a week, right? Compared to the traditional folks of moderate activity, where they label as roughly around 3 to 3.3, and that's including in-person visits. Mm-hmm. And so it's not rocket science. People just did more, right? They were more engaged. They were more active. And I think it's part of it is they built a relationship with the human, the clinician, through the technology, through the messaging, through the accountability, and through the virtual visits encounters that they had as well.
So they did everything was virtual visits with an animated.
No, so it was still with a clinician. A therapist was managing them, but okay. The therapist would prescribe a program, right. And that program would then be delivered on the Reflexion system platform. Okay. That platform was led by an avatar. An avatar who guided them through the exercises, educated them on how to do the exercise, why are they doing the exercise, and then used a 3D camera so it captured the movement and presented that movement back to the clinician in terms of a video and some feedback on what they were doing correctly and incorrectly. So the clinician was getting this asynchronous data, and they didn't have to be with them, right? And so it's all about extending the reach of the therapist to patients. And now, again, the therapist always had the ability to bring the person in for an in-person visit. Mm-hmm. The patient could always come into an in-person visit as well if they wanted it, because they just didn't feel comfortable with the technology, or if the physician and the physician's team felt the patient may have been a little bit behind clinically and needed some hands-on care. So, when you compared the two, over time, the real big savings was in the readmissions, because the clinician, the therapist, had more eyes on the patient through the technology. They were able to mitigate and reduce readmission rates, and so that's a big dollar savings there. In addition to that, they were able to also understand, when does the patient need to have in-person care and when do they not, and through that, they were able to manage the utilization a little bit better, differently. And so they still did virtual visits, but the in-person visit utilization was, there was a difference in there, like 70% difference, 80% difference in utilization. And so that kind of also led to some of the savings in dollars as well.
Sure. Question. What about I'm curious about the clinician satisfaction. I think even me and Dan have talked before with people saying that it seems like the patients and consumers have buy-in, but it's actually us that don't have buy-in. Like, how many people have told me I just don't like Zoom. And whether you like it or not, it's here to say it. So what was the clinician's satisfaction?
The key thing with this is, I always say it is, you can build a great product for the patient, but if the clinician doesn't find it useful, it's not going to get to the patient. So it doesn't really matter. And so, again, this was not a Zoom per se, right? This was more of asynchronous telemedicine, right? So where they're prescribing home exercise programs, collecting that data, collecting patients, assigning assessments to them, surveys to them, where they were doing it remotely and capturing that data. And it's funny you mentioned that, when you asked that question, Adrian, because couple of the clinicians, who did this were Duke PTs who wrote this. So this wasn't managed by our therapists or us at all. This was all done at a distance. Duke took our technology. They found their own therapist who managed it. We did it at a multi-center trial. So it was at 4 different sites around the state of North Carolina where they were managing them. And their therapists at first, they were kind of hesitant, reluctant. How's this going to work? Total knee. I don't know. The funny thing is, once the trial was done, those guys joined us as part of our team afterwards, and kind of because they wanted to be part of the tradition, the new model of care, because they found more job satisfaction. Right? Unfortunately, one of their spouses had a medical issue, so they couldn't go into the clinic as often, but they were still able to help the patient and work from home with this technology. So that was very satisfying before this pandemic. And this was 4 or 5 years ago. So this allowed them to have that job satisfaction a little bit better. And so the clinician satisfaction was quite high because of that. And because of that, if the clinician has high satisfaction, they engage with the software more, they engage with the patient more. Therefore, the patient engages with the software more. Because if you give a technology and there's no reciprocation on the other end, that technology will fade over time, right? It's not going to keep the person engaged. They need that reinforcement, positive, negative, whatever it may be. And if you don't provide that through automation or over time, but even humans, right, which I think is right, a little more manual, it's going to fade. So fortunately for us, we had really good clinician satisfaction.
Yeah, great point. I think almost anything in rehab, and we've had, new equipment, new technology you bring into the clinic, or a new piece of equipment. Even, I had a pool in my office, and if the therapists have to be engaged with the technology and have to make sure that the patient is excited about it, or help the patient be excited about it. Once they understand it and they, engage and they start using it, they're going to, they'll take it away. They'll run with it probably.
They'll eat it up. They'll eat it up, right? For sure, definitely.
Yep. But I think that sort of passion for the product, the service, really gets the ball rolling. Yeah. So where is, if you can tell us, where is Reflexion Health now, or where is the product you guys developed?
Yeah, so Reflexion Health, near the beginning of the pandemic last year, was acquired by a medical device company. So a medical device company now has the technology and is incorporating into their suite of digital health technologies, and kind of delivering as part of their med device sales. So it's exciting. I was there from the beginning, right? I was besides the co-founders and that, I was the first official employee. So it's like my baby. My baby's gone, and but still living on. And I'm very happy for that. But and looking forward to seeing where they continue to go, and as new opportunities open up for me, right? Sure. And new adventures as well.
So do you see that technology being integral to value-based care, and how?
Yeah. So I think for me, value-based care, you have to figure out a way to how you can, because telehealth 1.0, I think was ignited big time last year, 14 months ago, because of the pandemic.
Yeah.
I've been beating my head against walls, right? And I'll be honest with you, like doing this telehealth since 2012, and trying to get therapists to adopt technology in practice. And obviously, at that time, there was no reimbursement model. So value-based care was the only place to go, as the BPCIs were spinning up, bundled care initiatives and that. And talking to therapists, but therapists were still understanding and managing in the fee-for-service world that I still have to, because unfortunately for them, they're being evaluated in their clinic or in their health system on a how many revenues per unit, right? How many values are they bringing for the revenue? And so it was hard for them to comprehend and understand. And so, value-based care is more population management, and I think technology is the way to go for that, because you have to this is, I think there's a stat out there where it's saying only 10% of all people who need outpatient PT get to PT. There's 90% of the people out there who are unable to get to it, don't know about it, or can't afford it. So if we can increase that 10% to even 20% or even 15%, there's a lot of patients out there who need musculoskeletal care or musculoskeletal assistance. And if technology can expand our reach and expand our ability to help those who may be able to get in, I think, and that's part of where value-based care is that initiative, and it starts there because of the reimbursement, unfortunately, right? And where that reimbursement world is. And as that evolves, it'll change, right?
Yeah,
it'll change.
Because I think the flip side is, and certainly from a therapist point of view, is that technology, they don't want technology taking their job, essentially. And you're saying something that's you're really looking at it completely different. You're saying if we can incorporate technology, there will be such a larger pool, such a bigger pie of patients,
right?
Because so many more people than are actually receiving the services need physical therapy. So that's half the battle right there, or that's half the story. That the number of potential patients is significantly bigger than what we're actually.
And then you can use this technology to triage who needs to come into the clinic, or who do you need to go to see, right? Because
segmenting,
right, and understanding that, because I know when I lecture at universities on telehealth, you go in there and you ask students, okay, how many people have done telehealth? And this is pre-pandemic, right? So things have probably changed now, but pre-pandemic, and maybe out of 100 students, maybe 3 or 4 people come up. I'm like, all right, how many of you have actually helped a friend or family on the phone through a problem or give them exercise? Nearly everyone's hands go up, right? So the concept of understanding what is telehealth, right, is there. You still get to practice within your profession, within your guidelines, and you still help that person. Now, doesn't mean they're cured, but they can. You can guide them for a couple of weeks and say, try this for a couple of weeks. Check in with me. If it doesn't work out, come into the clinic, or let's find someone in your area to go in and see, right? And it's just not all digital, all in person. It's that thing that we've talked about, Dan, many times. It's the hybrid model, right? And understanding where to turn that dial for the person. It's not just one way or this way. And I know I keep on going, but when therapists think about this replacing them, I don't think technology can replace a therapist. And I've said it to you many times and to others. It's not the technology is going to replace a therapist. What's going to replace a therapist is a therapist that uses technology, right? Because the therapist that uses technology is going to understand how to connect with their patient better. Look at all around us, right? Amazon, Grubhub, DoorDash, all these things now, right? All these things have made things more convenient, and patients are consumers. And what do the consumers value the most is their time. So if you can give for those who value time and a convenient way of getting your service in a really kind of high touch, high concierge type of delivery model, patients are going to be appreciative of that, and that model will grow over time.
That's great. That's a really interesting point, that telehealth might actually even take off even more once people go back to work and life becomes hectic again.
That's right.
The value of it becomes even more, because you're increasing access, helping them manage their time.
Look at Peloton, Tonal, all these Tempo, all these at home gym things. They're taking off as well. Same concept, right? People, you can say, well, the big box gyms are, they're always going to survive. It's changing a little bit. It's not going to go away, but it's changing a little bit. Some people are going to work out from home now, right? And do things a little bit differently. Doesn't mean, but when we talk about telehealth, it can't be telehealth 1.0, because telehealth 1.0 won't survive, because that's not efficient. That's still one-on-one. Let's have a conversation for 40 minutes so I can bill you for 40 minutes of care.
Right.
That's not going to work, right? It's going to
Right.
be, if I need to talk to you for 5 minutes, let me talk to you for 5 minutes. If I need to talk to you for 15, great. But let me also capture data asynchronously, right? And I think that's going to be the key. 2.0 is really more using more technology, machine learning, AI, all those big buzzwords to kind of have that asynchronous model be more kind of ubiquitous to everyone, right? It'll be just available to anyone and everyone.
Yeah, talk more about that. Telehealth 2.0.
Yeah. It's, to me, it even goes back to what you said about you talking about what you're doing with your telehealth of the messaging, right? To me, I think the messaging, text messaging, and the HIPAA compliant, that is more.
Yep.
That to me is more of a stronger kind of engagement factor to a patient than sometimes a televisit, right? Just being able to answer, respond to a question, that just keeps them coming back for more. And understanding what a patient is doing when you're not with them is going to be key, right? It's happening now for chronic care management with, heart rate and blood pressure and weight scales and CHF. And it's gonna expand into our world as well, right? How can you understand how a patient is moving, not moving? What are they doing? How are they performing? All these different factors at home, right? And I think I listened to your conversation with Mark last week, and I think Mark is great, and he's doing some amazing things over at Vori, and what he's done is success already with previously, and it's the same adage. If we don't change, there are going to be other people coming into our space are going to take over and do things differently. And that's the challenge, right?
Yeah. So you hit on asynchronous, which is where a patient is essentially deliberately recording themselves or deliberately, I guess, recording and sending it to the therapist.
It's recording, or it's also capturing data, right? It can be doing a survey. It can be doing answering questions. It can be doing some education. All right. It's not only always recording a video. There's so many different. It's answering text messages, right? Responding to the things. So all of those things, I think, to kind of help you understand how that patient's doing, in addition to video recording, in addition to biometric capture of their emotion, right, is all important, right? And all will lead us to understand how that patient is doing, and over time build these models of predictive analytics. So saying, hey, if I see Adrian walk in my clinic and have him do a couple of motions, I'm going to be able to predict his recovery time based on some of these models over time, regression models over time, right? I'm going to understand that, this lack of motion or this he's going to be with me for this many times, or it's going to give you a better idea where patients are going to fall on that curve of recovery.
That's pretty mind blowing, actually.
Yeah.
I mean, look, we think we can process that and figure it out. I mean, I think I have a pretty good idea looking at a patient just from my own experience and running my own algorithms in my head, I guess. But if you have the scientific data and evidence behind it, that changes things significantly.
And it's objectifying. It's objective. It's objectifying our what we see. I think we are movement experts. We see all these things, right? We can watch someone's gait and everything, great. But then we can notice, Trendelenburg lean, decreased stance time and all this. But what is the exact precision of that, or what is the exact? Unless you really spend the time and have a massive, expensive kind of gait lab in your clinic, or you have someone walk on a piece of and map it out and draw it out and all those things. You're making some quick visual estimations, right? And so if you can use technology to give that a little more hard numbers, it can help with understanding the progression of the patient and their baseline and how they're doing over time as well.
Sure. So I'm going to talk like I'm going to go back a little bit. So I think a lot of people who understand telehealth and know the definitions. We think of synchronous, which is what we're doing right here. Asynchronous being some of the things I described before, a recorded session or survey, things like that, and remote patient monitoring being the third. Now, the way you speak, the lines are blurred. There's a lot of gray areas between what's asynchronous and RPM. Do you see any need to delineate that, or do you delineate that in your product development, or like where's your thinking on that?
Great question. So to me, I kind of think of RPM as a component of asynchronous, right? I think that's part of it, right? So obviously, if you can measure some physiological parameters remotely, right, then that's the key. And just where you don't have to be there live to do it, and you're kind of automatically capturing that data, right? There's a lot of things out there from different types of wearables where you can wear a sleeve on your arm or your knee and capture information, or a brace, or putting sensors on or straps on, right? There's all these different ways of capturing that data. And I think, to me, unfortunately, I think I blur them a little bit, because I kind of put everything as asynchronous and as a component of that, because it's just a way for me to really.
In our world, in PT, it's not as clearly delineated as right, as like taking your like a pin a pinprick, I guess it is, for like a blood monitoring, or whatever other monitoring that a primary care physician might be doing, or a different doc.
You're right. So right now, I'm going to throw out some codes here. Right, there are remote patient monitoring codes: the 99453, 454, 457, and 8. Those codes are codes that are now primarily just for MDs and their staff.
I was going to say, right? You're not even allowed to say those codes.
Yeah. Those are not for us,
I mean, like,
right?
PTs can't use those, right?
PTs cannot use those codes, right? And just to be clear, and by
the way, it's remote physiological monitoring, isn't it?
It's remote monitoring of physiological parameters of RPM of physiological parameters.
Okay.
And the examples are blood pressure, heart rate, weight, scale, all those things, right?
So we need it to be remote patient monitoring.
And then, I think it's remote patient monitoring. I don't think it's physiological, but then the example is of physiological parameters.
Yes, gotcha.
Right. And so, I'm going to add a caveat, but I always advise people to talk to your billing thing. A PT who is billing under the license or the NPI of a physician,
right,
does have the ability to use those codes.
Incident 2,
right?
Which we have our issues with, but
correct.
Go ahead.
That's a different world.
Different issue.
That's a different issue. But as I say all that, I think there's opportunity there, and there are some potential things that are coming. I think that may be coming down the path in 2022, which will. I think there's a recognition, especially the pandemic again has heightened everyone's awareness to this, where there'll be other opportunities to open this up to other healthcare medical professionals beyond the physicians, right?
I think they've just been doing it for longer as well. Like we're just starting to do the asynchronous and capture all this data, and maybe physiological might go into biomechanical or even force production. So
that's right. So I think the key thing is, when they talk about this remote, the data has to be captured remotely, right? And automatically. It can't be something that's captured, in other ways. And so that's part of it. And I think if you can capture some physiological parameters, remotely, automatically, I think that can help you with that. And so it's interesting. I think there's opportunities coming down the line. And you mentioned earlier, Dan, about the continuation of the telehealth codes right now through the because of the health because of the pandemic and everything. And again, I think it's great. I think it's the first step, but I think there's a bigger picture here. And as we were talking before this, as this kind of develops a little bit, this telehealth model, there's going to be ways, I think, to rethink how payers offer the benefit of physical therapy to their members, right? Because right now, like we were talking before, some insurance companies offer 12 visits per year, right? And if a 7-minute e-visit is equal to a 45-minute in-person visit, and to a patient, they lose one of their visits.
Sure,
it's going to be harder for them to do that, right?
Yeah.
And so how do we kind of change that model a bit and change it from visits to almost maybe code number?
It is one of the great values of telehealth, by the way.
Yep.
That you can do a 5-minute visit with a patient sometimes.
Right.
5-minute, 10-minute, to answer a question or help them through a cramping hamstring or whatever it may be, right? Or ice versus heat, and get you should get paid for that.
Right.
And the patient shouldn't be penalized and have to sacrifice a visit. So you should be able to bill for whether it's one code or 5 minutes or 10 minutes, even on a per minute basis. I mean, it just makes so much more sense.
It does, because that'll open up the option, the ability to really use technology as a way, right, and out there to help people.
And of course, we're talking within like the insurance framework. I mean, there are PTs or other practitioners who are already doing that on a cash basis or subscription basis.
That's right. And and I think that goes back to your earlier point of talking about value-based care. This is where value-based care gets pushed to the forefront again. Case rates, value-based care, right? Because then with value-based care, you just deliver the care that's needed. You're not really worried about billing. You're just worried about managing. And that's a different mentality.
Such a different mentality, exactly.
Right. And I think that's the key when it comes to that. And that's where technology can help a lot, when you are there to manage a patient and manage the recovery, more than kind of having to, bring them in as often as we can, unfortunately, at times, right? Which is important for them. They need that in-person care, but sometimes maybe not as often, and you can spread it out more too, right?
Yep. So you can say something, Adrian?
Yeah.
Okay. I want to get a little nerdy here, Anang.
Yeah.
Tell us about FDA and how that relates to what the products you've developed and the ones you're developing. Like, why is the FDA involved?
Yeah, so I think the FDA, we chose to go down the FDA route just for, I think, to have that.
This was Reflexion now, right?
Reflexion. Okay. To do that, just to make sure that we are following good practice guidelines for developing a quote unquote a software as a medical device, and especially since we wanted that FDA kind of symbol, to make sure that we are doing things by the book, and being able to say that we are FDA cleared, right, as a software.
Okay.
So it was more of a we took it as an approach, as a differentiating approach, and because we thought it also help us in terms of conversations with payers and conversations with as that comes into reimbursement models and new reimbursement models, right? Because when you look at the definition of a remote patient monitoring for the MDs, it does say that the device needs to be meets the definition of a medical device defined by the FDA, right? And so it's making sure that's why if you're following those development processes and manufacturing processes there to make sure that you are mitigating risk for yourself and for your patients.
Okay,
overall.
I get all that. Now, correct me if I'm wrong here, because I don't know, but I've been told that in the telehealth PT space, there's sort of like a line where you do need FDA approval, and before that you don't. The line is where there's actual decision making being done by a machine, based on obviously on algorithm or some sort of pathway.
Just like the goniometers we use in the clinic, they're FDA registered and cleared, right? That's an
but
FDA
they don't
product.
need to be.
But it is, right? So they are, right? A weight scale, that's an FDA device, right? So FDA is not something that has to be kind of that has all that algorithms and kind of diagnosing part of it. It could be a simple thing based on. So you have to look and find your product code that defines you, right? So just to make sure that you're following good, again, practice guidelines of developing your software or developing your product, and making sure it has kind of the safety checks as you develop it, and making sure you are developing what you're saying you're developing, right? And that they're always going back and it's good practice, more or less.
Well, that's for health or medical devices, correct?
Pardon me?
That's specifically, you want to say that yours is a medical health device.
Right, medical device, right. And it can be medical device, can be medical, there's cleared, there's approved, and registered. There's 3 different types, right? And so it depends on what is required based on your product. So at the time of Reflexion, we had to go through the FDA clearing route. So we had to do something called the 510K, right? Now with things like, something, if I build a goniometer, another type of goniometer, I just have to use, because at the time when we did Reflexion, there was no predicate. There was nothing else that was doing that. So we had to go through that route. Now, if there's something that was there, you can compare yourself to something that's already approved and say, hey, I'm the same thing. I have the same risk profile. I don't have to go through the due diligence route. I can just go through your registration route and say I'm equivalent to this other product, and here's why, right? And this is how I proved it out. And so that's the the nuances as things develop and changes, and that's why I think the FDA is looking, they're looking at the regulations and management of these apps, right? The wellness and healthcare apps out there. They're not quite in there yet, but they're considering doing things right down the road just to make sure.
Yeah. So, all right. So now, without giving away your secret sauce and any top secret information, what are you working on now? And what can we expect from you in the next year or so?
So I'm working with a new company. I joined them. It's called IncludeHealth. They are a company that's based out of Columbus, Ohio, and it started with the vision of the CEO, who's a designer by trade, and really he saw a person struggling to use equipment in the gym in a wheelchair. And so they started initially in this connected equipment type of world, where they built this beautiful kind of equipment where it was allowing people able-bodied or people of disability to use equipment very easily and freely, and let them adjust it on their own. Kind of a universal machine, but have it connected with a kind of a cloud application, so a clinician can deliver prescribed programs on that system to them, and they can adjust it, and it will adjust it automatically to them. And so
in the home,
that was more in the clinic. That was more in clinic.
Oh, okay, gotcha.
Right, and so as they developed that, that was a great concept, great idea. But the people would tell him, like, listen, this is one equipment. I have all this other equipment in the clinic that's not on your platform, which you think is great. So what they did, they built some sensors that would go on that equipment to kind of digitize some of the traditional equipment, like a leg press, another machines that you have in the clinic, that would digitize them by telling the person, what sets, what reps, what weight to set, showing their force output, all that stuff, and capturing all of that and feeding that back into the clinician portal. So now, as a clinician, you can see what the patients are doing objectively in your clinic as well, and assign it to them, so that when they go to that kiosk, they can just sign up and do it. And when this pandemic hit, things changed a little bit, and they kind of started looking into other technologies and other ways. And it was actually announced yesterday a little bit. The company itself has been collaborating with Google on some models of body tracking models for the last 5, 6, 7, 8 months. And so, we're kind of their case study for their new models that are coming out. And so the next progression is to now understand what a patient's doing everywhere, right? Not just in the clinic and not just in the community, but also what they could potentially be doing at home as well, and delivering it on some other devices, right, type of thing. So
yeah. So are you guys doing the sensing, the monitoring, the movement?
So this is the difference. What we're taking the approach is this, right? We're building a software platform we're calling it the kind of a MSK operating systems, right? So we're for the clinician. So we're not here to build another digital clinic or network. We're actually here to build technology, a telehealth digital technology that the brick and mortar clinician can use and do it at a low cost, where they can now themselves kind of create a telehealth model in their clinic. And like we talked about very early on, I'm very big on the hybrid model. And I don't think it's all digital. I don't think it's all in person. It's the hybrid model. So now, if every clinic can have a telehealth option, low cost option to deliver an asynchronous model along with a synchronous model, as the reimbursement evolves and changes, that's what we're trying to do. Is really empower the clinician to do that.
So I have a question. I guess I'm a little confused. So is it a motion capture system? Is it take data? Is it Is it
Yeah, so
telehealth or like, I guess, yeah,
it's a
what
little bit
is
of
it?
everything. It's a little bit of everything. So we're very early in our development, but it is a technology that is using um, uh, the machine learning models of body tracking and using any device, anytime, anywhere, on any device, and using the front facing camera. So there's no hardware and there's no software, so there's nothing to download. So you don't have to ask your parents to go into their into their app store and download an app or anything. It's just it'll be something that goes to their phone or their email. They click on it and opens up, and it's tracking them. It's telling them what to do and how to do it, um, and what they should be doing better, and what they need to be doing, and everything. Again, everything is managed and controlled by a physical therapist or a clinician.
And curious, what is your role? Like, I know you wear a lot of hats, but like, what do you? Are you the subject matter expert, or do you have the
Yeah,
product, FDA? Like, what do you? What
yeah.
exactly do you do now?
So,
Tell
so
me.
my title is chief clinical officer, and as that, it kind of it's a multi hat role, right? Obviously, it is subject matter expert based on my previous history with reflection and coming in on body tracking and camera based technology in the home. But at the same time, it's also helping with product development and product roadmap, working with our product team, our head of product and our engineering team, to making sure we're making clinically uh, relevant decisions and building a clinically relevant product. In addition, it's also working with our sales team and implementation, where we're focused on. I go into the sites and our customers and help with implementing the product, showing them how to use it in the clinic, and eventually at home with their patients, and kind of that sales support as well. So,
Sorry about that. Going back to now, I feel like I ask this question every week now.
Yeah.
How are you guys dealing with the Big Brother issue? Meaning, like, people fear of being monitored.
Yeah. I think it's being transparent with the patient that, hey, we are. It's such the communication from the clinician. The clinician's gonna make the patient feel comfortable. So the clinician being able to explain to them what the technology is going to do, what's the benefits of it, how it's going to help them manage them, and it has the capabilities of managing, monitoring them, and at the same time giving like I said, letting the patient know, as a clinician, it gives me more information about you, so I can help you more.
It's
right?
for their benefit.
It's for their benefit, and if they don't like it, it's not for them. It's not for everyone. It doesn't have to be for everyone, right? It's healthcare. Not everything is the same way. So you find those who it'll work for, and some people, and it'll surprise you. Some of the people who will actually use it or find benefit of it or want it. Um, it's surprising sometimes, right? When you don't think, I'm not going to ask this person because they're a 76-year-old person who lives by themselves. But when you ask them, they're like, oh yeah, I'll use it. Why? Because it's hard to get to the clinic. It's not easy for me to drive or ask someone. I don't want to ask other people to drive me into the clinic, or I don't want people to come into my home, right? And so all these different things. And so just having that another tool in our toolbox to help a patient is the key, right?
Totally. All right. I've asked all my questions. Now, Anang, you get a chance to ask us a question.
Yeah, it's obviously I love what you guys are doing, and Dan, we've been talking for a while about telehealth and moving, from where you were previously and everything. But like, what do you guys really see as the biggest hurdle in telehealth adoption?
In physical therapy in particular?
Yeah, in physical therapy, yeah, in our world.
I mean, obviously there's multiple hurdles. One, forever it was payment reimbursement. There's definitely there is the hurdle of provider adoption, but I think that's going to be easily overcome. Mostly because there's just enough providers that are excited to treat either in a hybrid model or strictly from their home or strictly remotely. It's I don't know. I mean, the biggest one doesn't seem to be patience. It's more about it goes back to the old, like, docs don't really know what we do.
Yeah.
Right. And anytime I've had conversations, well, not all doctors, but a lot of doctors who I talk to are just like, no, my patient needs massage. We need someone to really get in there. I mean, we know that we're going to teach them how to manage that themselves.
Right.
We know that we're going to teach them how to stretch themselves. In addition to the idea that I can see everything you're doing on video, by video interaction and of course other modalities that you've talked about.
Right.
So I think it is just the overall understanding of what we do as PTs and where our value is. That's always been a challenge, and I think it will continue to be in this space.
I think these are the biggest challenge. I think we fought for so long to be manual therapists and get manipulations into practice acts and manual therapy, even back from Stanley Paris days coming to the States. So I think it's partly, just kind of giving it up that we have an identity. It's part of an identity. And I think it's ourselves that are going to be the first one out, even though, sometimes like we're in an echo chamber. We think a lot of people are willing to adopt it, but there's a lot of providers who are like ready to go back into the clinic. And, telehealth is like thing in the past, like pandemic was only a year ago.
I'll tell you that we're talking to someone, or I think there's a Becker's conference going on where they're saying telehealth has gone from 96% utilization down to 10%. Right. Yeah. And I think you're right, Adrian. I think that is part of it. And, even through my lectures too, when we talk about that, when I went to students, they always say, well, I just paid all this money for my hands. And I think sometimes what we forget and realize, the hands are very important. Well, what's the most important part is your clinical decision-making in your eyes, right? And that's the stuff that you use your hands to verify that stuff. But you already have a good clinical hypothesis of what's going on. Yeah. We all know we can watch someone walk down the street and know 3 or 4 things I'm going to work on them just based on how they're walking or standing or whatever it is, right? And so, but you're right. I think the hands is a big part of it, and it's that fear of losing that, right? And losing that, and I think it'll come because I think we have to adopt to what sometimes the market's wanting us to do.
Right. So, I think we're gonna skip like where you're talking about these, as I like a smart clinic or smart therapeutics. They're going to kind of go above because that might democratize a new graduate not having the experience that we do to see somebody on the street. And with a couple of pushes of a button, you get to find out their biomechanics or impairments pretty quickly. So I think we're going to kind of just...
Well, why can't we get a Jiffy Lube report on how that patient is moving before we walk into an eval room? Have them do a couple of motions, get some readout, right? And get a readout of their ability to squat, to ability to do single leg balance or walk, and get that Jiffy Lube report, and then come out and say, okay, now I know I have the metrics. Now let me tell you what you need to do to get better, right? Set out the plan. Practice at the higher end of our license, right? And so,
right, exactly,
like a physician practices, right? Be the manager, be the director, right? Sometimes,
it's also. I mean, I think what you're also describing is a synergistic moment where you're taking all the strengths of technology, combining that with all of the strengths and values of a doctoral trained PT.
That's right,
and they're inevitably just going to be more powerful.
That's right. And again, and this goes back to what I said. It can't be just about technology alone. It has to be about the human connection with the technology. So,
great wrap up. I like it. All right, man. This has been great. What a great conversation. Yeah. Awesome. I can't wait to get it up. Can't wait to post it out there and get it out there. How can people reach out to you? Where can they find you online?
Yeah, so
can you give everybody your cell phone number right now?
Yeah, my cell phone number. Give me a shout. Right? Text message me. That's true. But I'm on Twitter at AnangChokshi, at AnangChokshi DPT, and also on LinkedIn. Please reach out to me. I'll respond to all the times, or as well. My email address is my first name last name at IncludeHealth.com. Reach out.
I'll vouch for that. I reached out to you cold about 2 years ago, and like that we were on the phone. We were chatting. We were.
That's right.
Have a great conversation. So
love to talk about it. So
thanks, man. It was great having you. Adrian,
it was great meeting you.
As usual, likewise. Great job today.
Yeah. Awesome.
All right, man. I hope you enjoyed this episode of the TelePT Connections podcast. Thank you for joining us. Please remember to leave your comments, subscribe to the podcast wherever you get your podcasts, and join us again next week when we talk regenerative medicine with Dr. Jennifer Solomon. See ya.
We hope you learned some things to help you connect with your musculoskeletal system and more. Find us on Twitter at dseidler, that's DSEIDLER, and at Adrian MPT, ADRIAN MPT, and on LinkedIn, Daniel Seidler and Adrian Miranda. We'll connect with you again next time.